Chibis, I'm Aiwe, and today we are talking about ADHD through menstrual cycles, pregnancy, postpartum, and menopause. If you enjoy stories like this, hit the like button and subscribe if you haven't already. Let's go. What if the same brain, using the same diagnosis and the same coping tools, suddenly feels unfamiliar? A person can manage work for years, then struggle during part of a menstrual cycle after giving birth, or in the years before menopause. That change is real, but its explanation may involve several systems at once. In the next 10 minutes, we will separate what research supports from what is still speculation and build a safer way to understand ADHD across hormonal transitions. Act 1. The diagnosis does not change overnight. ADHD is a neurodevelopmental condition. It involves persistent patterns of inattention, impulsivity, hyperactivity, or difficulty with executive functions that affect daily life. Symptoms can look different with age, environment, stress, and responsibility, but hormonal changes do not create ADHD from nothing. This distinction matters because a difficult month can feel like a new disorder. Someone who once compensated with rest, urgency, exercise, or intense concentration may discover that those strategies no longer cover the same workload. The underlying traits may have been present for years. What changed could be the biological and social conditions surrounding them. Dopamine is part of the story, but not the whole story. It participates in motivation, reward processing, attention, and executive function networks. ADHD research points to differences in several neural systems, yet low dopamine is too simple to explain an entire person. Brain chemistry varies by region, task, timing, and individual history. Estrogen can influence parts of dopaminergic signaling, including synthesis, release, receptor activity, and reuptake. That gives researchers a plausible mechanism for hormonal modulation. It does not prove that every lapse in memory or burst of irritability is caused by estrogen, or that a laboratory hormone value can predict how someone will function on a particular day. The useful question is therefore not, do hormones cause ADHD? It is, when hormonal conditions change, do they alter the threshold at which existing ADHD difficulties become impairing? Act 2. The missing data problem. For much of ADHD's research history, study populations included far more boys and men than girls and women. That shaped the image of the condition. Overt hyperactivity and disruptive behavior were easier to notice than internal distraction, exhaustion from masking, disorganization hidden by perfectionism, or years of compensating quietly. Girls and women may be diagnosed later or less often, although there is considerable variation. A late diagnosis can bring relief, but it may also reveal years of self-blame. Someone who was repeatedly called careless, lazy, dramatic, or unmotivated may have built an entire identity around failing to meet demands that were genuinely difficult. This is not evidence that ADHD in women is a completely separate condition. There is a substantial overlap across sexes and genders. It is evidence that context affects recognition. A person who is compliant at school may still be struggling intensely. A person who performs well at work may be spending every evening recovering from the effort. Research gaps also affect hormonal questions. Older studies often did not record menstrual timing, pregnancy, contraception, postpartum status, or menopause. Without those details, researchers cannot easily tell whether a symptom pattern is related to a hormonal transition, a change in sleep, a new medication, or a heavier load of caregiving and work. The word women also describes a diverse population. Research focused on cisgender women who menstruate may not generalize to transgender men, non-binary people, people using hormonal contraception, or people receiving gender-affirming hormones. Biology matters in specific contexts, but gender identity, social stress, and access to care matter too. A gap in evidence should lead to careful investigation, not confident internet mythology. Act 3. The monthly pattern. Across a typical menstrual cycle, estradiol generally rises during the follicular phase, reaches a peak around ovulation, and changes again afterward. Progesterone is usually higher in the phase after ovulation. Real cycles vary, and hormonal contraception can change or suppress these patterns. Some people with ADHD report more difficulty with attention, task initiation, emotional regulation, motivation, sleep, or impulse control during the late luteal or premenstrual phase. Small studies, surveys, and clinical reports support the possibility of cyclical worsening. They do not establish one universal pattern, and they do not justify a standard medication schedule for everyone. A related condition is premenstrual dysphoric disorder or PMDD. PMDD is not simply ordinary premenstrual discomfort. It involves severe cyclical, emotional, and physical symptoms that cause functional impairment. Diagnosis generally requires prospective tracking across cycles because memory after a difficult week can exaggerate or blur the timing. Tracking can be surprisingly informative. For several weeks or months, someone might record attention, mood, sleep, bleeding, medication timing, caffeine, illness, and major stress. The goal is not to prove a theory. It is to see whether symptoms follow a repeated pattern, remain constant, or appear alongside another factor such as insomnia or depression. The same caution applies to medication. Some preliminary findings and clinical reports suggest that perceived effectiveness can vary across a cycle. But a perceived change may also reflect missed doses, appetite changes, poor sleep, stress, or altered routines. Controlled medication should never be increased, supplemented, or shifted without a prescriber. Practical support does not require treating a cycle as a rigid productivity timetable. A person might place extra reminders around a predictable difficult period, break complicated tasks into smaller actions, prepare meals in advance, or reduce unnecessary decisions. These are flexible supports, not rules about when someone is allowed to be ambitious. And a pattern that looks hormonal still deserves a broad clinical assessment. Act 4. 3 major transitions. Puberty can change how ADHD is experienced, partly because hormones and brain development are changing at the same time that academic and social demands become more complex. The evidence about ADHD and the timing of first menstruation is limited and inconsistent. ADHD should not be used to predict early or delayed puberty. Pregnancy and early parenthood create a different kind of pressure. Sleep may be disrupted, routines become less predictable, and the number of tasks requiring planning can multiply. Depression and anxiety can occur during pregnancy or postpartum, and they should not be dismissed as just hormones or blamed on ADHD alone. Medication decisions during pregnancy and breastfeeding require an individualized risk-benefit discussion with qualified clinicians. Evidence differs by medication and remains incomplete. Stopping treatment suddenly can also carry consequences, so the safe approach is coordinated care rather than a universal instruction. The postpartum period deserves particular attention because severe depression, anxiety, intrusive thoughts, or a sense of being unable to cope are medical concerns, not character flaws. Suicidal thoughts, mania, psychosis, or fears of harming oneself or a baby require urgent professional help. Perimenopause introduces a different overlap problem. Fluctuating ovarian hormones can coincide with sleep disruption, hot flashes, mood changes, forgetfulness, and difficulty concentrating. Those experiences may resemble ADHD, but they can also occur with depression, anxiety, thyroid disease, sleep disorders, medication effects, or chronic stress. Existing ADHD may become harder to manage during this transition because the person has less cognitive reserve available for compensation. At the same time, midlife can bring intense demands: employment, caregiving, relationships, financial pressure, and responsibility for older relatives. The final result may be biological change plus an environment that leaves no margin for error. The timeline is not a straight line from normal to broken. It is a changing interaction between brain, body, sleep, treatment, and demand. Act 5. What care can safely do? Evidence-based ADHD care remains relevant at every life stage. Depending on the person, it may include stimulant or non-stimulant medication, behavioral strategies, psychotherapy for co-occurring conditions, environmental supports, accommodations, and treatment for sleep problems. Menopausal hormone therapy is not established as a general treatment for ADHD. It may be appropriate for selected menopausal symptoms after an individualized medical assessment. Decisions depend on factors such as age, timing, symptoms, medical history, cardiovascular and clotting risk, cancer risk, and the type and route of treatment. Hormone levels are not the same thing as hormone effects. Two people with similar laboratory results may feel very different because receptors, sleep, stress, medication, and other medical conditions differ. A single blood test is therefore not a complete explanation for fluctuating attention. A useful appointment begins with a timeline. When did symptoms start? When do they worsen? How are sleep, mood, bleeding, medication, caffeine, and major responsibilities changing? Is impairment present throughout the month or only during a particular window? Could PMDD, depression, anxiety, thyroid disease, or a sleep disorder be contributing? Bring observations rather than conclusions. A diary can help a clinician compare symptoms with cycle timing and life events. It can also prevent a common mistake, assigning every problem to ADHD because the diagnosis is already available, or assigning every problem to hormones because the timing seems persuasive. Build external support before demanding more willpower. Use written routines, alarms, visible medication organizers, task decomposition, accountability, and realistic workload adjustments. These tools do not prove a hormonal theory. They simply reduce the amount of executive function that a difficult day must supply internally. The larger lesson is a threshold model. ADHD may set a baseline level of effort required for attention and organization. Hormonal transitions, sleep loss, illness, and stress can lower the remaining reserve. When demands stay high, a system that once worked may fail, even though the person has not become less intelligent, caring, or disciplined. This model also explains why no single intervention can be universal. Medication may help one layer, sleep treatment may help another. A menopause treatment may address hot flashes or related symptoms without treating ADHD itself. Calendar changes may help with workload, while therapy may address anxiety or shame. Better research should ask not only whether symptoms change, but for whom, when, under which hormonal conditions, and alongside which treatments. Studies need to include different ages, cycle experiences, contraceptive histories, pregnancy and postpartum periods, menopause, transgender and gender diverse participants, and the social conditions that shape access to diagnosis. ADHD does not need to be erased, and women and people who menstruate do not need to be forced into one biological template. The goal is more precise understanding. Hormones may change the environment in which ADHD symptoms are expressed, but they do not define a person's worth, and they do not automatically explain every difficult feeling. If this topic connects with your experience, track patterns without diagnosing yourself from them. Bring the record to a qualified clinician, and do not change medication or begin hormone treatment on your own. If you found this useful, consider subscribing for more evidence-focused psychology, and share what questions deserve better research.